Hello, my name is Christine Saracino from Maimonides Medical Center in Brooklyn, New York, and I'm going to be talking about the utility of lumbar puncture and emergent neuroimaging in children with complex febrile seizure. Before we begin, I have no financial interest to disclose. Seizures are associated with both acute bacterial meningitis and intracranial pathology. However, the incidence of acute bacterial meningitis, as well as the incidence of clinically important intracranial pathology, is low in the population of children with complex febrile seizure who present to the emergency department. As a result of these low incidences, establishing predictors of these outcomes has been difficult, which has led to a slew of invasive testing as well as exposure to radiation for neuroimaging. The objectives of this study were to determine a set of predictors to distinguish those children with complex febrile seizure that was due to either acute bacterial meningitis or clinically important intracranial pathology from those who did not have these conditions. We performed a retrospective cohort of consecutive patients who presented to an urban emergency department between the years 2009 and 2019. We included all children aged 6 months to 6 years with complex febrile seizure, which was defined as fever plus a seizure that was either prolonged or greater than 15 minutes, recurred within a 24-hour period, or had some element of focality. We excluded all children who had a previous history of non-febrile seizure, an immunocompromised state, an underlying medical condition that predisposed to seizure, a VP shunt, or known trauma. We performed a computerized search of the medical record, and we looked for patients who had diagnoses of either febrile seizure, complex febrile seizure, simple febrile seizure, intracranial bleed, brain tumor, meningitis, or seizure plus fever. We identified 2,038 patients in our EMR, and these charts were manually reviewed. 260 of these patients met the definition of a complex febrile seizure. 19 of these patients met exclusion criteria, and 241 were eligible for the study. Data extracted from the chart included age, gender, ethnicity, maximum fever height, physical exam findings that were concerning, seizure characteristics, whether or not an LP was performed and the results of that lumbar puncture, whether or not neuroimaging was performed and the results of that imaging study, as well as whether any medical or neurosurgical intervention was made based on those results. We recorded whether there was an admission to the hospital or a return visit within 30 days. Of the 241 patients studied, they had a mean age of 21.9 months and were 46.7% female. 37 patients presented with a seizure duration greater than 15 minutes. 33 had seizure focality, and 189 had more than one seizure in a 24-hour period. There were several children who presented with more than one of these features. 19.6% of the children we studied had a lumbar puncture performed, while 22.1% had neuroimaging performed. Of the children we studied, 0 had a diagnosis of acute bacterial meningitis, and only 2 were diagnosed with clinically important abnormal neuropathology. Of these 2 children with abnormal neuroimaging, they both had multiple seizures within a 24-hour period as a defining feature of their complex febrile seizure. The first of these cases was an 8-month-old male who presented with fever and 2 seizures in 24 hours. He was also noted to have altered mental status and a full fontanelle. His CT findings were consistent with acute non-hemorrhagic infarct. He was intubated, given mannitol, and received IVIG for suspected autoimmune encephalitis. The second case was a 10-month-old female with fever and a 10-minute long generalized tonic-clonic seizure followed by multiple absence seizures. She was noted to have her neck rotated to the left with minimal movement of the right side of her body. Her CT head and MRI brain were both consistent with bilateral otomastoiditis, and she was admitted to the hospital for IV antibiotics. Other interesting cases were a 17-month-old male with two seizures in 24 hours who was found to have enterovirus meningitis, a 13-month-old male with two seizures in 24 hours who was found to have CT changes consistent with demyelination versus chronic ischemia, and a 20-month-old male who presented with prolonged seizure who was found to have MRI changes consistent with demyelinating disease versus PVL. In conclusion, there were not enough outcomes of interest for us to determine a predictor of acute bacterial meningitis or clinically important intracranial pathology. However, the low number of outcomes of interest may indicate that the risk of these outcomes is low, and we may not need to do the routine testing via lumbar puncture and neuroimaging. Both of the patients in our study who had clinically important neuropathology had other concerning physical exam findings, which likely would have prompted the emergency physician to order a workup. In conclusion, more studies with a larger number of patients are needed. Thank you.